They're the people we hope never to need, but when an emergency occurs, they're all we depend on.
Ambulance emergency.
Okay, tell me exactly what happened.
Don't do anything for the meantime and put the knife away.
Filming with 999 call takers, emergency paramedics and their patients. This is the story of the men and women of the HSE National Ambulance Service.
I don't know everyone in Wicklow just because I live in Wicklow.
You feel a bit dizzy. Sit down there before you fall down because I won't be able to catch you.
This time, how a quick reaction can be a matter of life or death.
If the heart stops or anything happens to the heart, it has a huge effect on people.
Every minute goes by that patient's in cardiac arrest without CPR. The chances of survival is cut in half.
Pump the chest hard and fast, at least twice per second and 2 inches deep. 1, 2, 3, 4. You're giving them the best possible chance, okay?
Nobody wakes up in the morning and chooses to suffer with depression.
What happened? Are you hurt anywhere?
And with increasing demand on the ambulance services, every case is different and no 2 days are the same.
They don't get the fact that they weren't breathing and probably would have died. So they're a call that you have to be really on your toes with.
Depression is all around us, you know. There's a lot of people in Ireland who suffer with depression. It is a recognised illness, the same as any other, and I think people should remember that.
I suppose a big thing in our calls at the moment would be depression, mental health issues.
03 gone red. That's 25-year-old male there. I got a fall on the street, conscious and breathing.
That's all received, thank you. 25, straight 25 about to fall.
Sometimes in our job, it's like, again, we might be able to bring great treatments to the person, so we might need to do medical interventions, or you might need to give them drugs and things like that to help them. Sometimes it's more of like a counselling job where you go and you talk to the person.
Nobody wakes up in the morning and chooses to suffer with depression.
Hello, can you hear me? How are things?
A lot of the times it might be that they actually have a diagnosed illness, and more times it can be drink related. You'll find that you meet a lot of people on a regular basis, and it's usually they get depressed when they're after drinking.
How are you? We're paramedics with the ambulance here to help you. What happened? What happened? Are you hurt anywhere?
He was sitting.
Yeah.
Sitting leaning against that, and then he looked over and he was just lying.
Yeah.
They don't want any interventions. They don't want you to take their blood pressure. They don't want you to take their temperature. They really don't care. Sometimes they're sitting on the edge of the street and they just can't go on. They physically can't get themselves up to go home, so they just sit down. And sometimes you just got to get down on the knee, hold their hand, and just let them talk it out. You be the sounding board, you know?
It's what? All right. What's your name?
And a lot of the times it's just that they want company and that they want somebody to talk to.
Do you want to sit up for us? We'll take a look at you. No? We get you up off the footpad anyway, will we? Yeah. Come on.
There's nothing you can do. They're sick in their own way. They need to go into the hospital and they need to be taken care of.
It becomes more of kind of a counselling job than anything else, and sometimes you have to use an awful lot of skills getting somebody even to get to the vehicle.
Will we help you up? Yeah? Come on. We'll help you there.
Okay.
All right?
1, 2, 3.
Good man. That's it. Okay.
Now we go down here to the ambulance turn.
You see the ambulance there? We'll help you down and we'll just make sure you're okay. Is that all right?
Yeah.
Okay?
There we go.
That's it. Mind the old steps now.
We'd probably know a lot of them on a first name basis, and they'd know us as well when we actually go out to them. It's not always easy to figure out who you're going out to, because a lot of these people might be homeless, so you could be picking them up from different locations, or that they'd be living in different hostels around the city.
Come in here, so with us. Good man. Now, do you want to sit on the bed or do you want to sit up in the chair? You want to go on the bed? Yeah, absolutely. If you'd like to go on the bed, we'll put you on the bed.
You don't have to get out the magic box and, you know, put the oxygen on. Sometimes you just sit there and you just hold their hand because they're just at that point in their life where they can't take anymore.
Were you in hospital recently for the eye? In the Mercy. Okay. All right. And what do you think happened today? How was it you were sitting on the footpath and things?
I didn't want to go back to Vincent's.
You didn't want to go back to Vincent's, all right. We'll just do 1 or 2 quick small checks and then we'll bring you down to the hospital. Is that all right?
I think sometimes like a kind word and a bit of reassurance, and just trying to do the best you can for them, and like realistically in the ambulance service all we can do is lend an ear and try and get them as far as the mental health services that are trained people to do their job to help them.
So, you know, we're here to help you and all that, yeah? Okay? Just here to do the best we can for you, okay? Is that alright? And it was a nice lady rang us and just because she was concerned for you because you were lying on the footpath, okay? And are you feeling a bit more depressed today than normal, or are you a bit worse today, do you think?
We're not trained to counsel people, and we're not trained to cure whatever is their problem. We're there to get them to an accident and emergency department and to the services that can assist them.
I will lose you, pop you into the Mercy anyway and get you sorted today. Make sure you're safe and everything's okay, alright? Yeah. Get somebody to chat with you. Get you a cup of tea and make sure you're sorted and you feel okay before you leave, alright?
Nobody can throw stones, nobody knows what's going on in their lives. A lot of the times when you talk to them and listen to them, there might be drink problems, they might have lost children to social services just because of their conditions, and everyone has a story to tell.
We'll bring you away in the bed because you're nice and comfy, alright? Okay?
There is services to help them, and there's, the psychiatric service and the mental health services within the health service are very good.
Alright? Go up.
Sometimes you have to really be able to use all your skills and understanding and getting somebody to the hospital, and a bit of reassurance and a bit of a bit of sympathy towards people and a bit of humanity towards them.
We have gone to a lot of people who they are not ringing an ambulance for a medical issue. They are ringing an ambulance because they don't know what other options they have.
It's actually so sad, the amount of people out there that feel that much in despair that the only way they feel they can escape from it is to attempt or to actually harm themselves.
It's a part of the job I never really expected when I came into it. When you think of an emergency call taker, you think of the obvious things, bleeding, cardiac arrests, everything. You don't really think of the suicidal thoughts or the depression side of it. It's such a big part of our job as well. We have so many people ringing us for help.
It's a call people probably don't realise we see as much of it as we do because it's not publicised. I suppose there's still a stigma attached to a family member committing suicide, so it's not one that families will broadcast a lot of the time.
It can be a very, very sensitive subject. It can be very tough for the caller, and it can be very tough on you as well.
Generally when they ring in, they're looking for help. They don't really want to do what they think is their only route away from the problem. They're really looking for help.
They might want to just talk to somebody, and for that person to tell them that it's okay to keep living.
Ambulance emergency. Thank you, and tell me exactly what's happened.
It is a lot more prevalent than I ever imagined when I started in this job.
And how old did you say he was?
You cannot put people into different categories, that this type of person is more likely to do this. My experience is that it can be anybody from any walk of life.
Okay. Was this accidental or intentional? Intentional. Okay. Is he violent? No.
And it's very, very hard to deal with those people on the phone.
Yeah.
Hello, is that James?
Okay. And when did he take it?
James, my name's Brian.
Okay. All right. I'm organising help for you now. Stay in the line. I'll tell you exactly what to do next.
As a call taker, I have certain responsibilities and roles that I have to do. I have to get them done. Once I have those done, I can then sit and talk to them as a person and try to deal with them and talk to them as a human being and as somebody that is trying to help in the situation.
It's hard going to people like that because you try and empathise with them as much as you can, but you obviously don't know what they're going through and you can never understand their situation, but you try and reason with them in some kind of way and try and just talk to them and try and, for a better word, counsel them.
Okay, tell me exactly what happened.
They can be quite difficult, but a lot of the time they're willing to have a chat with me and just talk things through, and I'll basically I'll be reassuring them that I'm going to stay with them until help arrives.
They find it a lot easier if they ring someone like yourselves and get the ambulance out rather than going to approach someone. So they ring us as a last resort.
Look, like I said there, just do me a favour, unlock the front door, okay? So just keep an eye out for them, okay?
So you can find yourself more or less acting as a counsellor to these people.
Okay, I'm just going to ask you a few questions and then we can have a little chat, okay?
You can just make a person feel so much better just by talking things through and just asking them, what happened and what has made you come to feel like this.
No, don't do that now, okay? Don't do that.
You know, if someone is seriously thinking of taking their lives, obviously there's an ambulance on the way. The guards will be on the way as well at that stage. And you're doing your best to talk to that individual as a person.
Okay, just listen to me now. I want you to sit down and relax for me for the moment. Okay, I know, I understand you're very upset.
We're not counsellors at the end of the day, we're not social workers. There is limits to what we're physically able to do. But I can tell you now that every call taker in there will try their best.
Don't do anything for the meantime and put the knife away.
Recently I had one guy, he was threatening to stab himself while he was on the phone to me. So I had to diffuse that situation and talk him down and just have a chat with him, make him feel calm, make him feel like there is actually somebody there who's going to talk to him, someone who's going to listen to the problems that he does have.
Yeah, we're going to get you that sort of help. We're going to get you the right help you need, okay? Yeah, we are on the way.
I'm not just a robot at the end of the line. I am actually a person too who's able to empathise with these people. So it can be rewarding to be able to calm them down and make them change their mind about taking their own lives, basically.
Don't make those calls. And they can be difficult calls. General calls like that, we try and follow up with the crews to see how was that individual.
Times like that, would be the time where you just, after you take the call, you just go outside and get a bit of fresh air, because it can be very upsetting,
We have critical incident stress management teams and we have colleagues, we can talk about it.
And if he gets worse in any way, just call us back straight away on 999.
You always have that support, genuinely, within the control room, that if you need to step out and go and get a cup of tea after a bad call, no problem. There's never any issue at all with that. And people will follow up on it to see that you are okay.
Do you think he's beyond any help? Do you think he's beyond help?
Everyone has their own different way of dealing with stuff. Me personally, I don't smoke, but somebody gets a bad call, they go for a cigarette break or something. I tend to just go up, grab a cup of tea, come back down. Because at the end of the day, it doesn't matter whether it be the worst call or the best call, you're going to have to take the next one.
For ambulance crews, domestic and psychiatric calls for help have become a common occurrence. That is easily dwarfed by a much larger social issue.
Drug overdoses are so common at the moment. Luckily though for us, when the calls do come in, we're given a good chance to help the patient and to get CPR rolling before the crew arrive on scene, and luckily the outcome is good in that sense, but they're unbelievably common.
Heroin overdoses are very prolific at the moment in Cork.
And it's becoming more and more regular. I mean, at one stage there was one of my colleagues here and he went to a house and both people had stopped breathing, and he was literally bagging one fella. He was breathing for one fella and just going over and breathing for the next fella and going from fella to fella until another crew arrived and assisted him with the second fella. So it's a scary drug in that sense.
There's a 51-year-old male there who suspects a heroin overdose. He is conscious and breathing there at the moment, but he is bone blue in colour. He is now completely alert. He has took it in the last half hour. Over.
14-07, that's all received, thank you. There's always a bit more urgency to get there because we know once that person stops breathing, it's only a matter of a minute or so before their heart will stop. And it's one thing if they're not breathing to get them back breathing, but it's another thing if their heart stops to try and get their heart going. It's a different kettle of fish altogether for us.
A lot of things depend when they took it, how long they're into the cycle of the heroin, and when we get to them, how fast we can bring them around, basically.
And you're sure there's no needles around here?
No, sure.
Okay.
Basically, our initial assessment when we get to the patient, we can see the drug paraphernalia around, so we know it's an OD call. If we're first on scene, sometimes you are, sometimes you're not.
They're a strange call in that when you get there, the patient can be practically not breathing or barely breathing.
Blood sugar is 8. Yeah, you can do on that side. There you go.
We can give them a drug that will reverse the effects of the heroin. It can work quite fast, and the patient will actually come around and probably stand up talking to you.
How are you keeping? You can just relax. We're paramedics with the ambulance. You're quite safe. Okay? You're quite safe. All right. Just relax down there. We'll pop a wee needle into the hand and we'll pop you down to the A&E. Is that okay? All right.
And if they are using heroin, the chances are that there's going to be needles around the place. So even to kneel down to help them and that, you have to be so careful. So to us, they'd probably be one of the more dangerous calls. And you'd be very likely to get a needle stick injury if you weren't careful.
Usually they will come around fairly quickly because you're breathing for them and you've given them a reversal agent.
Yeah, we'll try and get him into the wagon. I think with the O2 he's okay at the moment.
Most heroin users will get very irate and angry at you for ruining the experience that they have paid for.
They don't get the fact that they weren't breathing and probably would have died. All they can see is the amount of money that they spent on their heroin that they took, and it's our fault now that they have gotten no buzz from it, even though they wouldn't have realised that they had gotten a buzz because they were going to be dead if we hadn't intervened. And those calls can become very violent very fast. So they're a call that you have to be really on your toes with.
You alright? Do you know where you are? You're in an ambulance. We're paramedics with the ambulance service, okay? And we're here to help, alright? Good man. Do you understand? You do. Okay. An awful lot of the heroin users we go to are quite, believe it or not, nice enough guys, right? And we normally wouldn't have an awful lot of hassle from them even if we do give them the Narcan and we start breathing again. What time did you take the heroin at? Was it just before we were called, was it? You don't know? I think your buddy was saying about a half an hour ago. Most of them are reasonable enough people, and they're, they might be upset initially, but they're not violent towards you or anything like that. You get an odd chap that might be a bit violent towards you, but usually we have a good enough all dealing with these people.
14-07, go ahead. Okay.
So we just grabbing another call here, so.
It's a clear arrest at 32.
Cardiac arrest. Ambulance! Sharps, okay. Good stuff.
It is checked the date and all.
Super. So the last call we were at there was heroin overdose again. So we arrived and one of our other crews was there and they were managing his airway and they were breathing for him. So he wasn't breathing again. We gave him some drug to reverse the heroin, but this time it took 3 doses of the drug to actually bring this chap around. So he must have had quite a lot of heroin in the system. But again, like one of the problems that always crops up when you give these people drugs to reverse it is that they don't want to go to hospital. No, I'm grand, and they're standing up and they're grand and they feel grand, and they're refusing to go to hospital. So it's a huge dilemma for them because we know that the drugs we've given won't last as long. So it's any kind of, any way you can get them to go to hospital, any way possible, we always try.
It happens with every drug addict, irrespective of what drug they use. They don't actually believe that you're bringing them around because they weren't breathing or because they were in arrest.
Obviously you have a concern for them and you voice that concern to them, but if they've their mind made up, the chances are you won't persuade them to travel with you.
We, as a service, cannot force someone to come to hospital with us. We can only advise them.
What you have to be concerned with in our job as well is if this chap isn't breathing properly for a bit, if the oxygen hasn't been going to his head, are his decision making correct at the time? Does he actually realise, and has he the capacity to realise what we're trying to explain to him? Eventually it was good old Irish mammy convinced him. So although she said to me, but I'm not his mammy, but any Irish mammy will always convince a fella to go to do what they're told, I suppose. So you pop in as far as the accident emergency department with the other crew, provided he doesn't cause any hassle along the way and create a bit of hassle for them. And the A&E will just take over his care. They'll keep an eye on him for a few hours, make sure that his respiratory rate doesn't fall back down again. And after a couple of hours, as long as they're happy with that the drugs are out of his system, they'll just send him home basically. If his respiratory rate does go back down, they'll do the exact same as we did. They'll just give him a drug to reverse it, the same drug as we use here in the ambulance, and they'll just keep an eye on him getting in for a couple of hours. That chap was respiratory arrest, heroin OD, and the crew are going to take him as far as CUH. We're clear and available, over.
The most common calls we get are probably for the elderly. They're a huge demographic in our population at the moment, so they have a lot of health issues and social issues as well. Like, they can be people living on their own, not able to manage, from to somebody who has like a chronic cardiac condition. So they're probably our bread and butter.
It's a 1-year-old male. He is conscious of breathing, but it's complaining of shortness of breath. They came in there from the emergency response unit team there. Over.
Roger that, all copied.
Just as the budget was about to start.
What?
Just as the budget was about to start.
Well, just now, we're better off out not hearing these things.
One of the calls we went to, it was very much a social issue. It was an elderly gentleman living alone. He was just not managing on his own. He called it in as a shortness of breath. So what have we got? Conscious with a breathing issue.
That's it, 91 years of age. When you go to somebody who's quite elderly, they generally can be short of breath, generally unwell, dehydrated, and sometimes their problems might be multiple medical problems. That means they might have a respiratory problem going on, they might have a bit of a kidney infection as well at the same time, and they probably have a temperature. I'll hop out, okay?
Yeah.
And get it organised. And when we arrived and seen this chap was there on his own and he was feeling unwell.
I'm going to take your temperature. Little probe in your ear, okay? His big issue really was the fact that he wasn't able to cope on his own anymore. He'd pressed his alarm, so he had like his little home alarm, and he'd pressed that, and that had called the ambulance for him.
You have a bit of trouble sleeping, do you? Very bad sleeping. Yeah, okay. But is there any medicines that make you sick that you can't take at all, is there? Aspirin you can't take, good man. He was communicating well to us, so immediately we realised there was no life-threatening emergency. You not think you're very warm? The heating's on in the house and you've got about 10 layers on you there.
Yeah. With that arm as well, Ted. Good man.
Put all that on in 5 minutes.
That's grand, I get it there.
The heating was on. I think he did a little gas fire going in the corner, which would be robbing the oxygen from the air as well, so it probably wouldn't be helping. But again, that's back to him not managing his environment correctly and needing help.
I'm just going to scratch your finger to get a drop of blood out.
None left.
There is loads.
Between Vincent and Michael.
They're taking it all, have they?
Have they? Our most important job in dealing with the elderly is communication. And just been speaking to them before you start sticking temperature probes in his ear and taking blood sugars, is to build a rapport with the patient. They're quite elderly, they're quite frightened, and sometimes they're actually quite lonely, living on their own during the day, even if they're waiting for people to come out in the evening. No pain anywhere?
On and off. Yeah.
Where?
All over.
Okay. Once you can talk to your patient, it's very, very important. They will volunteer most of the information for you.
They do struggle when they get older. Family moves away and they're left to manage on their own, and if they have a partner and the partner passes away, then it can be easy to forget that they're not able to manage as well as they were 10 years ago. So yeah, that does come up a lot.
Tell you what I'm going to do. I'm going to take some of these clothes off you because you're a bit too warm, I think. I'll put the cardigan back on you, all right? There you go. And we leave the dressing gown off you, okay, because it's quite mild outside. We just took our time. There was no major rush. We administered some nebulizer to him because he was short of breath and he was a little bit wheezy.
We're going to bring you down to hospital, Ted. Okay, we'll bring you down to hospital.
It's a very frightening experience when you can't breathe properly. It's, I suppose, like any of us, if we run up a hill and you get that shortness of breath, but it goes again. For him, this wasn't being relieved by anything. He was sitting down and he was finding that he was gasping for air. So we can give some medications to help that. We can give him oxygen, we can give him salbutamol, and the advanced paramedics can give further medications to help that.
Ah, right. Now, young fella, we'll get you to come over here, all right? When you go to somebody who is elderly and you arrive in the home, it's important that you try to make them feel at ease and that you're going to look after them as best you can. And don't be frightened. You've been on this before, all right? Okay, bit of a bump. Okay. There you go. And you're not going to watch the budget today, no? They don't want to leave their homes. They're quite elderly, they've lived there most of their lives. And quite a lot of elderly people, when you arrive in a big yellow ambulance at their house and guys are coming in white shirts and yellow jackets, they sometimes a little bit easy. Sometimes they can feel that they may not be coming back to the actual house themselves. So you have to deal with them in confidence and with a bit of dignity at the same time. That's very important.
91.
91. You're going to head for the 100 to get the outfuba off the president, aren't you?
All right, so we'll go down to hospital.
What did you work at?
Postman.
A postman. That was a good noble trade.
Yeah.
This chap was a postman, and his father before him was a postman, and he had great history and he'd seen great changes through the years, and he wanted to talk about it. And I think that's important, that you are able to listen to the elderly and listen to what they have to say. They're part of a community after all.
How are we doing, Joe? Everything still the same?
Yeah, it's actually settled down nicely.
So we brought him down to the local hospitals where he'd get treated, and we would say it to the receiving staff that maybe a social worker needs to get involved, a community welfare nurse needs to get involved as well, and give him a help. It's sad to think that anybody ends up, where they're at home and not able to manage, but it's a reality in society today.
Ambulance crews are frequently faced with a large variety of situations and scenarios that no call taker or paramedic likes to see.
A cardiac arrest to us is probably one of the more serious calls, and where there's a lot of work done for the patient pre-hospital.
Today's cardiac patient can be anything from a minor chest pain to angina, somebody having a heart attack or having a cardiac arrest?
Physically, it's probably one of the tougher calls because it's so physical. Doing the compressions could be a long length of time. But I suppose nowadays, with first responders and local community groups, you'll usually have extra hands at scene.
By their very definition, they're a very chaotic situation. The person has been found by a loved one, usually. The person cannot get this person to respond, so panic immediately sets in.
They can be very hard to deal with, especially when you're dealing with somebody on the phone who has zero medical training whatsoever.
It can be very hard sometimes, especially when you get an elderly couple who have been married for 60 odd years and their partner has just collapsed.
You can have a son or a daughter doing CPR and a parent, or just a normal passerby walking down the middle of the road, someone collapses in front of them.
They will automatically go into a 9 echo response if the person on the other end of the phone says they're not breathing, I can't get a pulse from them.
You can be on a call and think you have control of it and you have your patient in the best possible place and you're doing your best for them, and things can change in, pardon the pun, in literally a heartbeat.
Everything's colour-coded and the cardiac arrest calls show up in the system as purple. So regardless of where you're standing or sitting in the room and you see something tag going purple, you know, something serious has happened.
Ambulance emergency. Straight away you get in and start giving them CPR instructions. Ask them, is there anyone there beside you can send for a defibrillator? Or is there one available anywhere near you? Well, you send someone to get it now.
If there's a defibrillator available, can you send someone to get it now, okay? Is there a defibrillator available?
If there's a defibrillator available, all well and good. I for one think that they should be everywhere. I think everyone should have some sort of CPR training.
What I need you to do is make sure your husband's lying flat on his back, okay? Okay, and remove any pillows. Have you done that? I want you to do CPR for me. Can you do that?
In the meantime, you're getting them started on chest compressions. Just trying to keep that person going, or trying to bring them back, whatever the case may be, trying to keep them going until help can take over.
Is CPR in progress? CPR's in progress with the doctors, okay.
The early CPR starts, the better, because every minute goes by that patient is in cardiac arrest without CPR, the chances of surviving is cut in half.
Ambulance emergency. You need to be kind to them, but you also need to be firm, because a lot of people can be distressed and they're just not able to process the information. Okay, just listen to me now. I told you already the help is on the way, okay? You need to listen to me, you need to calm down so I can help you, okay? Now, you need to pass the phone to someone who's going to go up there beside that man. So you need to say to them, okay, put me on the phone to somebody who is willing to listen to my instructions, or just calm down and listen to what I have to say. Okay, lay him flat on his back, please. Okay, what I want you to do is, you want you to listen carefully. I'm going to tell you how to do resuscitation, okay?
Chest compressions, if you've ever seen them, they can be frightening. You might think that someone's being hurt, you know, but it's not. It's giving them the best chance. Place the heel of your hand on the breastbone in the centre of the chest, right between the nipples, okay? Put your other hand on top of that. Pump the chest hard and fast, at least twice per second and 2 inches deep. Let the chest come up all the way between each pump, okay? I'm going to count with you for 600 times, all right? I would talk them through how to open the airway, how to, lie them flat on their back, open the airway, talk them through CPR, and I'd time the rhythms for them so that they're able to count with me. So starting 1, 2, 3, 4. 1, 2, 3, 4. At that rhythm, okay? And I just keep reassuring them until help arrives. Just keep going, don't stop. You're giving this person the best chance of survival. Okay, just keep going until the ambulance crew gets there, okay? 1, 2, 3, 4. You're giving them the best possible chance, okay?
You're not there. So you're trying to tell these people that have no qualification, they're not trained in any shape or form, they've probably never done this before. Like everyone has seen it in a movie, everyone's seen it, it's completely different. Okay, I know you think that, but just keep going, okay? You need to stay strong here, okay? 1, 2, 3, 4. We're going to give them the best chance. 1, 2, 3, 4. 1, 2, 3, 4. Keep going, count out loud. You don't see any change, nothing's happening. The person is still not breathing, still unconscious, but you're still helping. You are, that's it. Still, you're helping more than you know as well. Now I need you to give him 2 more regular breaths into his lungs, okay? About 1 second each. Okay, do that now. As I told you before, put one hand on his head and the other hand under his neck and tilt his head right back. You need to do CPR until the ambulance crew arrives, because they have all the tools they need
to be able to give that person the best chance of survival. So you really need to keep that heart going until the ambulance crew gets there.
Don't stop until the ambulance crew take over compressions, okay? Even when you see them, don't stop until the paramedic takes over on his chest, okay? Well done. You're doing so well.
If we do have a save from a cardiac arrest, it's not me that saved them. It's actually the ambulance service as a team going to the control staff, to me, to the ambulance crew that's arriving, back into the hospital. It's actually a team effort.
Yeah, look to the left.
To the left, to the left.
We'd get a lot of calls out for chest pains, which can either be cardiac related or they can be respiratory. Just get up a bit of speed, you have to go right back down again.
We went out to a chap up by Balgoli and he was complaining of a bit of chest pain. Okay. Hello. What time did this start at? An hour ago. Okay. Just quick listen to your chat. Our first impression when we see somebody, you can see if they're sick or not sick. Exactly what we say. Sick, not sick. Straight away you know by somebody if they're sick. He was really pale, really sweaty, really unwell looking. You've been well the last few days and everything?
Yeah.
There's been nothing strange, no?
Not really, just headache, feel tired.
Okay.
Some people will be able to tell you that they have a cardiac history, and a lot of the times it would be because of the cardiac history. Sometimes it's new onset of pain. They would never have experienced it before.
It hasn't gotten any worse or anything?
They started getting clammy, that was when I thought, yeah, ambulance.
I suppose you have to listen to the patient and they'll explain to you exactly what happened, when it happened, what they were doing, and we can do tests.
Okay. He presented as if he was having a heart attack, so we did all our tests really quickly. We tend to go from like medium gear to high gear really quick if something's going on, and especially being from Cork, I tend to roll out questions really quick. We speak fast an awful lot of the time anyway, but when it's a pressured situation you tend to speak a bit quicker, and there's a bit more pressure on you to get things done a bit quicker, to see what's going on with people, because there's medicines we can give, drugs that stop clots forming, drugs that stabilise clots, and things that we need to be giving them really quick to reduce the effects the heart attack and things are having.
We can do ECGs of the heart and check out what rhythm the heart is in and see where we go from there. Some of these do turn out to be cardiac, but a lot of the times, especially depending on the weather and the seasons, they can be respiratory problems, where people would have chest infections and their chest is sore from the way they're coughing or trying to cough. So you really have to take the patient's history, their vital signs and a proper assessment of the patient into account.
The heart is the second most vital organ in the body. If the heart stops or anything happens to the heart, it has a huge effect on people. It's not able to pump the oxygen and blood and nutrients around to where it should be, so it's the vital organ that has to be kept going.
So what we'll do is we'll pop you into the ambulance, we'll get you up onto the bed, okay? We'll give you a spray of GTN once we get you into the bed, okay? And we'll pop you up as far as UH. Is that okay? Has the pain eased or anything at the moment? Still there. Okay.
Things have changed a lot in the last few years. There's more medications can be given to the patients depending on their ECGs, and ECGs are fairly new in the last few years as well. Prior to that we wouldn't have been able to do 12 lead ECGs, so it's all progressed in the last few years, which is great for the service.
So we'll do is we'll stand up with me just for 1 second and we'll just whip away the chair and put in the bed right behind you. Okay, so nice and slowly. That's it. Stand up for 1 second. Just going to put the bed right behind you. Okay. And sit straight back down. Okay, and you can just literally swing the legs up. Okay. Now.
He had to go to hospital to have further tests done just to be on the safe side, but he really looked like a sick chap.
Just a little bump when we go into the ambulance. There we go. You alright? Okay.
You'll always take the patients into the hospital, because even though we do a lot of tests at the side of the road and we can tell so much, they still need to have bloods done and to see the doctors, because there's obviously other tests that can be done that we can't do at the side of the road.
So all our tests at the moment are okay. Your heart rate's a little bit slow, but nothing drastic, okay? But all our ECGs are fine and everything, okay? What we'll do is we'll give a shout ahead to the hospital. We'll tell them you have a bit of chest pain, okay? And we'll get them to have a look at you. Is that fair enough?
There's a lot more can be done now prior to the patient getting to the hospital, and we can also go straight to the cath lab now instead of A&E if there's particular rhythms on the ECGs for the patients.
It's not a great road. We're going to Cork, yeah. Quite bumpy and things, isn't it? Bumpy and windy.
We will bring people directly to the theatre now. We don't even go to an accident, an emergency. If somebody is having a heart attack, we go directly to the theatre where they will have their surgery 5 minutes after we arrive in the door. They'll put a little wire into their femoral vein or into their radial artery, and they'll feed it directly up to the heart and dissolve the clot, or put in a special balloon to widen up the artery that's causing the hassle. And it's brilliant because people's quality of life after the event is way better.
So it's definitely an improvement for the patient and for their outcome as well.
The waters around Ireland are actually quite cold and they can induce sudden cardiac arrest.
I think at one stage it was like at 18 beats per minute.
The patient had severe pain, near 10 out of 10.
If you have been affected by any of the issues raised in this programme, please visit our support page, tv3.ie/helplines.